but let us understand some basic movements. This may be very basic for people who are already doing plenty of upper GI endoscopy, but let me just tell you. Big wheel, small wheel. The big wheel towards you, the tip moves upwards like this. Okay. So, you bring the big wheel towards you. So, you look at 12 o'clock, that is looking up. The big wheel away from you, it will go backwards. Okay. Next important thing is small wheel. Small wheel away from you, it turns to the right. Small wheel towards you, turn to the left. But same way, clockwise. For example, I told you already, clockwise like this if you do, then it is like this. If it clockwise it goes, turn to the right, and anti-clockwise, you turn to the left. So, like that you can do the torquing and also the wheel it is going to. And the next thing, you gently push and pull, and actually I say more you pull rather than you push. In other words, I say if you go one step forward, you prepare to take 2 steps, because only by forward and backward movement we have to travel, because we have only shorter colonoscopy to travel 2 meter or so. So, you should be very, very careful, and you should be minimum insufflation, very, very important, because insufflated distended colon becomes a long colon. A suction and a contracted colon become a short colon. So, we want a short colon. So, you avoid unnecessary air insufflation. Suction is a success for colonoscopy. There are other additional advanced movements as you can see here, that is, for example, there are scopes which will go for a passive bending like Columbus scopes, but you need to be careful not to do this passive bending or slide by. Blindly you never push. Always it is like driving a car. Will you go blindly with a leap of faith? You will not, you should not. So, you have to do all this jiggling, shaking, and right and left hand shortening. All these things are very, very important. Like what is mean by jiggling and shaking? As you can see, the pictorial representation is very clear. Jiggling is nothing but you have to go for the movement, in and out movement like that. Okay. When you do that, the bowel is like sleeve, it is coming concertina effect. So, you have to go, in other words, within 10 centimeter of your the scope, you are going 30 or 40 centimeter of sigmoid colon. This is jiggling. Shaking is side to side movement, like that. If you shake, what will happen is any attachment of the tip to the mucosa, it is not there, and it will travel in the middle path. So, you go in the middle lane, something like that. So, these are the shaking and jiggling, now and then you do. These are the 2 important movements what we call the right and left hand shortening. For that, as you can see, you take the scope, you bring the big wheel towards you. So, when you do that, it go on hook, it is like Spider-Man hooking on something like that, it will hook on. Then what you do, you go for the what we call the right hand torque, like the clockwise torque, and pull back. So, you just take the big wheel towards me, then you just go for the right hand torque, like that, pull back. So, this is one of the important thing when you are going for the reduction of the alpha loop. What about like a gamma loop? They just opposite I will do, just towards me again big wheel, but anti-clockwise torque and pull back. Okay, whether it is a clockwise right hand shortening, anti-clockwise left hand shortening. So, like that you can do all these things. I am sure by practice it will become a habit, and do all these tips and the steps I am going to tell you. It is all going to be piece of cake for you. First is patient in the left lateral position. What do you do? Examine in a good light, the anal examination, just note patient has no fissure, perianal sinuses, fistula, everything you exclude. Then lubricate, and with a double glove you do a rectal examination, because the last thing you want is not to miss any lesion in the lower part of the rectum. So, once you have done the rectal examination, throw that first glove, then you lubricate. Very, very important is what is shown here, how much of jelly I am putting it. The lubrication is a success for a smooth navigation. Next is when you insert, as you can see how you are inserting, either you can insert the scope tip or you can finger guided. You put the scope next to your finger, index finger, and insert as this thing says, like this. If you insert, it will be easy to go, and it will go towards the sacrum, and it takes a curvature because it comes and it will go become retroperitoneal like this. So, this tendency of forming an alpha loop is there. So, what you do, as soon as you put the scope, what you see is actually the upper rectum. what you do not see is the lower rectum. So, that is why the lower rectum is only felt by your rectal examination and is seen on your way out. There is the last, it is like a fundus examination of the stomach is the last thing we do, is not it, like a retroflexion. Similar retroflexion we will be doing to look at the lower rectum in a matter of, I will tell you in a minute. Next important step of course is the sigmoid navigation, very very important, because success of colonoscopy is how good you are in the sigmoid navigation. Do not ride on the air button, do not put lot of air, minimum insufflation. As you go, you just to follow. For example, here where are the, see, darkness. So, you have to go to the left there, and here it is here in the downwards. Here where is the hole? It is going up. So, the tinea coli, the dark areas will tell you where the likely site of the lumen. Accordingly, you need to drive your car. So, you try to do what we call follow the shadows, okay, to cross the bends, very very important, because as you can see here it is a clockwise torque. You can see how I am rotating clockwise like that, like that. So, it keep rotating. So, you can see from here by clockwise torquing you are trying to do, see, in other words it will go for the opposite direction. So, this one you prevent the alpha loop formation by doing this clockwise torquing. Otherwise, if you are not too careful, I think loop formation in sigmoid is more or less like a feature. It is not a, it is an incident rather than an exception. One of the common loop formation, especially in young women, is this one, that is N loop. You bring the pelvic colon into an intra-abdominal organ like that. It is like a iatrogenic sigmoid volvulus. Then sigmoid descending, it is a fixed area. So, it will not go. Every time when you push the scope here, it will try to make the loop bigger and bigger. So, what you have to do? You need to pull it. So, suck and pull back, then you make it like hockey stick like this. Okay, this is the way you reduce it. Only by confidently, courageously you keep on sucking and pull. At one point the area bend will be straightened, then you proceed. Okay, or other way is you push, you ask your staff nurse to push, so that from suprapubic pressure you will prevent this loop ascending in the abdomen. So, these are the two things. One, your assistant is trying not to make the big loop in the abdomen by suprapubic pressure, and you also pull back the scope and suck, you will avoid this N loop formation. What about this alpha loop? If you ask me, this is what we call the N loop, and this is what we call an alpha loop. As you can see, the alpha loop is already formed like an alpha like this. Here, as soon as you go, everything, because there is no acute king. So, it goes, it looks like a easy colonoscopy, easy. But what happens is, you spend about 90 centimeter, even a meter, but you haven't reached the splenic flexure. In other words, it already formed a big loop here, patient is painful. So, what you have to do is now, you have to go for the clockwise torque, pull back. So, this is what, if you do it preemptively before alpha loop formation, you can bring this. So, this is the way it is reduced. You can nicely see now the alpha loop has been reduced by the clockwise torquing. So, clockwise torquing before formation of alpha loop, or if there is a formation after the formation of alpha, if you keep on doing it several times, you will be able to reduce it. Okay? So, this is the importance of suprapubic abdominal pressure by your staff nurse to reduce the N loop, and this is the way the alpha loop will look like. By pulling back and clockwise torquing, this is the way you reduce, and this is the shortest route to splenic flexure, because if there is a shortest route like this, you should reach the splenic flexure at 40 centimeter. That is what very important. Okay? Because there are some indirect evidence to say, because we do not have the luxury of either a CT scan or even a scope guide to tell you where exactly the tip of the scope, but still if I push 1 centimeter of the colonoscopy, if I haven't seen similar movement in the monitor another 1 or 2 centimeter, that means 1-to-1 progression, that means I am looping somewhere, or every time I start pushing, patient says it hurts like undue pain, or if the control head is very stiff, or if I push actually the scope tip is receding, I am actually falling back. So, these are all the indirect evidence to say that you are already forming a loop. Better you correct the loop before you proceed any further. So, that is the next important thing. With all your bit of luck and all the tricks we have said, you will be able to reach the descending colon. Will tell I am here by seeing a typical fluid level. When you see a fluid level, usually the fluid level is somewhere in the bottom half, but it will be sometime like this also. Then it is a straight road like a motorway, you will be able to see the splenic flexure, because this is the way it will be classical descending colon. And when you reach the splenic flexure, the spleen with the bluish shadow and with a mucosal fold at 9 o'clock, you have to turn to the left there. So, that is where you will be able to see. But sometimes in acute splenic flexure, for example, here it is not an acute, you can very easily can go, but sometimes it will be very acute like here for example, then it will be very difficult. So, you change the patient from left lateral to right lateral. So, any difficulty at splenic flexure, what are the three important things you will do? One, suck all the fluid to have a clear view. Second, ask the patient to take a deep inspiration, so the diaphragm on the left side comes down. So, a hyperacute, the angle of the splenic flexure will descend. So, it will make easy to go, or ask the patient to go to the other side, there is a right lateral. So, these are the three tricks on the sleeve we should have. Okay. Then transverse colon. The transverse colon is very classical, because it will be a triangular configuration because of the prominent the tinea coli, 3 tinea coli, you will be able to see it like a pyramid, you can go like that. And how to reach from one end of the transverse colon to the other end of the transverse colon? Go slow, minimum insufflation, and suck all the fluid, because as I said, suction makes the colon little shorter. So, external pressure, but more important thing I would say is the suction. And once you reach the other end of the transverse colon, that is of course, then hepatic flexure, you will see the indentation or sometimes bluish discoloration of the liver. But it will not be like this most of the transverse colon, sometimes it will be like this hanging with a long mesocolon, it will make a gamma loop. Okay, then it will become what we call a treacherous, difficult to traverse transverse colon. So, in those alpha loop, there is a typical gamma loop. So, how to do a gamma loop? I told you already, is that left hand torque steering, that is what you need to do, shortening. So, you need to pull back the scope, then you have to go anticlockwise and suck. So, if you do that, very often you will be able to reduce this loop, but it is very rare, the gamma loop formation. Then once you reach this hepatic flexure, once in and out, then you see as if it looks like it is like a well, you have to dive into, as I say, you have to dive into the ascending colon, even though it looks like as if you are descending into the colon, but it is actually the ascending colon as the nomenclature, we call right colon to be precise, and there you enter, it is much wider, thin walled, you can see, and you will be greeted by what we call the classical, see this is the thing. Very important thing is a crow foot sign. You will be able to see the convergence of the tinea right at the end, like the 3 tinea, like a crow foot, are very important. This is a crow foot, and more important thing is at 6 o'clock or 7 o'clock, you will be seeing that shiny looking the lipomatous ileocecal valve. So, these are 2 things, but one of the other definite thing is of course appendicular opening. So, it will be also so. So, there are at least 3 signs to say that I am here. Just putting a pressure here and seeing, oh, I can see my hand pressing on the right iliac fossa, I am in the cecum, that is no good. So, at least one, but I would say all the 3 should be seen to be sure that you have reached cecum. But the 100% truth that you have done a complete colonoscopy, I would say, is by entering the ileum and saying hello to ileum. That is the only way I can take, because ileoscopy is a very important thing. You start from the beginning, I am sure after 100 cases or so, you will be able to reach. How to reach ileum, or how to cross the ileocecal valve? That is a $1 million question. For that, there are few things you have to understand. First is you identify the ileocecal valve, and where it is hidden here, okay, at around 7 o'clock, it is not the cecum is here, about 5 centimeter above the cecum, it is ileocecal valve is here, and here is the ileum is entering. So, here it is obviously seen here, it is obviously that is hidden, and this is the lipomatous fold, and this is the appendix. You imagine as if you are throwing an arrow from here like a bow. So, this is appendicular opening is like a bow, and you are throwing an arrow and the arrow is directing towards this bivalved or bilobed, the lipomatous ileocecal valve. So, here, so if you direct your scope, then it will be easy. The simplest thing is you go and reach the cecal pole like here, as you can see, and pull back the scope. As you pull back the scope, the big wheel away from you. When you see big wheel away from you, the scope goes backwards like this, and then as you do the suction, you will see the two lips of the ileum. Then you will be able to enter the tunnel, like what just now you can see the entered the ileum. All this villi will say I am here, and you can take a biopsy to prove that you have reached the ileocecal valve.